Hi, hello, good morning. Welcome to Introduction to Clinical Flow Cytometry. My name is Emily Fiore. I am a medical lab scientist, and I also hold my certification in molecular biotechnology through the American Society of Clinical Pathology. I currently work for St. Luke's Hospital on the Plaza doing flow cytometry. This is a newer position for me. I have been working here for a little over a year, maybe a year and 3 months at this point. So I threw together this talk for ASCLS Missouri this year because this is a new position for me, and I don't recall learning much about flow cytometry in school. I'm about 10 years out of school now, so maybe that's changed since I did it back in the day. But kind of what I remember learning was just a little bit about maybe how the machine works, but not really much about the theory and the analysis of the data. So that's actually what we're going to talk about quite a bit today. Just a little background on me. I am a blood banker by trade. Um, I spent the majority of my career blood banking at the University of Kansas Health System, and I love the blood bank. I'll always love the blood bank. But when the pandemic happened, they kind of went through everybody's resumes and said, hey, anybody with any PCR experience, hey, come help us do COVID testing. Come help us get that up and running. So that's where I ended up for what, almost 4 years. And kind of after all that, I just decided I wanted to try something completely new. And I saw this position open and I jumped at it. I work with a great team. I'm really fortunate to have a great group here at St. Luke's. So just very, very lucky. And very lucky that I've been afforded this time to be able to throw together a talk like this. So let's get into it. So the objectives I have for this talk for you today are I want you to understand the basic steps of the sample prep and staining. So we are going to talk a little bit about that laboratory piece. That's kind of the front half of the talk, but we're not going to focus too hard on that because we have a lot to cover for the analysis piece. I want you to be able to identify normal CD markers and staining of B and T lymphocytes. Flow cytometry in the clinical world for us is all about the lymphocytes. See, that's something I didn't really know, learning as a student. So we'll talk a lot about that. And then I want you to be able to identify some malignant hematologic conditions that can be well visualized by flow cytometry. So just like every area of the lab, flow cytometry is really good for looking at certain things and not other things. And we're gonna talk about what those things are. So flow cytometry, by definition, is a process of rapidly detecting and analyzing cells based on multiple differentiating parameters. Those parameters, just the basics, are forward scatter, which is size, and then side scatter, which is complexity, so your granularity, and then fluorescence, which is your surface and or cytoplasmic molecules that are tagged using antibodies labeled with different fluorophores. So I just kind of have this basic diagram here for you that kind of shows just a basic schematic of how the flow cytometer works. So your cells are going to get lined up in kind of a single file line here in what's called the sheath. And this is actually a running kind of sheath of fluid here that's getting those cells in single file line. Do they always stay in single file line? No, of course not. That would be too easy. We do occasionally have some clumping or doublets, but that's something that we can kind of figure out and you get used to looking at the data. And then we are going to pass a laser through those cells, and our cytometer has 3 different lasers on it. We have a blue, a red, and a violet laser. And then those lasers correspond to different fluorescence intensities that are coming off of those fluorescently labeled antibodies that we use to mark the cells for certain CD markers, which are those cytoplasmic molecules or surface molecules. Today, we are only going to talk about surface molecules. So just don't pay any attention to the cytoplasmic stuff. That's a little bit more of a complex topic. The dyes have names like PE or PE-Cy7, so some are conjugate dyes. Coming from the PCR world, that's not abnormal to have like a donor and acceptor fluorophore. I'm not going to get really too into how fluorescence works today, but just know that all of those things kind of complicate how you design your panels and the performance of your testing overall. So again, those are more advanced topics, but that's kind of where our starting point is. We run on the BD Fax Lyric, which can run 12 colors in one tube. So that's quite a bit of data you can get in just under 3 minutes, which is pretty cool. And then each one of these cells is going to kind of show up for us as a dot on a plot. So you'll get to see what all that looks like here in a bit. So just a little bit of history for you, because I didn't know any of this, and I did a little research for this talk. So CD markers are cluster differentiation molecules. These are molecules that are present at the leukocyte cell surface that can be used to further identify the cell. They can be ligands, receptors, adhesion proteins, etc. The numbers and names we commonly use, like CD45 and CD10, are defined by a working group of scientists called the Human Cell Differentiation Molecules Council. So I'd love to hear you guys say that 5 times fast. About every 3 years, that council holds a workshop to evaluate those new CD markers. So we don't just, science is always changing, right? We don't just stay with the same ones that we've had for however long. We're always evaluating whether we need to add new ones. And that workshop is called the Human Leukocyte Determination Antigen Workshop. So again, another very wordy name. The first workshop was actually in Paris in 1982. So you'll realize that this is actually like not a super old science. We've really only been naming these things for 40-ish years. We're currently on the 11th iteration of that workshop. So this is the 11th time that they've been meeting. And these first workshops back kind of in the 80s were focusing on working backwards from antibodies created around the world to form that naming consensus. So it's kind of like a which came first, the chicken or the egg. You'd think we'd work from the antigen to the antibody, but just the way the technology was, we didn't have the technology to be doing it that way. So it was more that we were working from the antibody towards the antigen. And different labs around the world were doing this and finding, oh, well, somebody names this antigen based off an antibody in one place, and then somebody else somewhere else in the world names it something different based on another place. So of course, we're all about making things complicated for ourselves. So this was a way to kind of claw that back a little bit and bring together some naming consensus so that when we study these things and learn more about the complexities of the immune system, we're talking in the same language. Because if we're not speaking the same language, it's going to be really hard for us to be able to, learn about this complex thing. So the way this works now is that antigens are identified by genomics or proteomics, and then the antibodies are made and tested against known cell lines. So for an antigen to be submitted to this workshop, there has to be at least 2 discrete antibodies made in 2 different laboratories, and then they will send those out and test them against known cell lines. And then that's what happens during each of these workshops. So then statistical analysis is performed and new nomenclature is designated based on the results of that statistical analysis. So you'll notice too that there's a name change here, right? So the Human Cell Differentiation Molecules Council actually was formerly called just the Human Leukocyte Differentiation Council, and they changed their name actually to just Cell. human cell differentiation molecules council, right, instead of human leukocyte. And that's because we realized that the immune system wasn't just about leukocytes, right? There's all these other cells that are being interacted with. And so now that nomenclature has been kind of expanded to include some cytoplasmic molecules, some stromal molecules, intracellular things. So we're not just looking at things on white cells anymore. For the purposes of this talk, we are really only talking about the white cells, but just know that the council that's deciding on CD markers isn't necessarily just talking about leukocytes anymore. So I thought that was a really cool and interesting part of the history. So here's a diagram maybe you've seen before, but maybe with some things on it that you haven't seen before. So this is a very simplified schematic of your white cell differentiation, right? From stem cell all the way to your lymphocyte or myeloid maturation. And this is very simplified. I don't have, we all know that like the myeloid stuff is a little more complicated than just, myeloblast to granulocytes, right? There's a bunch of stuff in between here, but for our purposes today, we're kind of going to simplify it a little bit just because it gets really complicated. But you can see that we have our CD34 blood stem cell here. And this is just giving you a taste of kind of how we use these markers to decide what lineages we're looking at. So CD34 is kind of known as a blast marker, and it goes all the way back to the stem cell lineage. And then, so you can see we have 34 in positive between the, or in common positive between the lymphs and the myeloblasts, right? And they're both what we call CD45 dim. But you see we have a difference here with the 117, the lymphs are negative, but the myeloblasts are positive. The 33 is positive on those myeloblasts, and the 13 is positive on those myeloblasts, but they're negative on the lymphoblasts. So that's just a little taste of kind of how we make these decisions and how you design your panels to be able to suss out what you're really looking at. Then we have, down here, I just threw in some of the things that we're going to be talking about today. We're going to be talking about CD19 and CD20 on our B lymphocytes. Flow cytometry is really, really good at looking at our B cells. And so that's going to be a lot of what we talk about today. Our T cells are CD3 and CD5 positive. We're going to talk about the T cells just a little bit, but that's not the big focus of our panels here at Luke's. And then our granulocytes are usually 10 positive. So those are just some kind of home markers to kind of home you to where we're heading. We're going to cover more of that. So I just wanted to give you a taste here early on in the talk. Common clinical applications of flow cytometry are hemoglobin F quantification, so for a fetal bleed into maternal circulation. And then we have CD4 quantification for our HIV patients. We have HLA typing, reticulocyte counts, and I believe this is the technology that's used on a lot of hematology analyzers. So you do have a little bit of flow cytometry happening, naturally just in your regular hematology lab. And then we're going to talk about leukemia lymphoma panels today, because that's the bulk of what I do in our laboratory. And we're mainly going to talk about mature B and T cell neoplasms, mainly the Bs. And we're going to talk a little bit about some myeloid disorders and neoplasms, mainly kind of your AMLs. We see a lot of plasma cell dyscrasias here at my place of work because we do have an older population. And that's just a disease that naturally is hitting that older population. We're not going to talk about that today, though those cases are really interesting. And I hope to someday in the future do a talk that's just centered on the plasma cell dyscrasias, your multiple myelomas, and your lymphoplasmacytic leukemias, things like that. They're really interesting because your plasma cells can have a different lineage than your B cells, and you can have kind of two things going on at once. So those are interesting cases. Of course, I had a little taste of that in the blood bank. Anybody, daratumumab came out when I was just a young tech in the blood bank. So that was a whole hurdle that we had to learn how to navigate. And of course, now it's pretty normal, and it's a drug that's pretty used for that disease. So here's kind of just a little taste of what the general workflow looks like in our flow cytometry laboratory. So you're going to get a sample and you're going to do some sample prep. And that involves checking a patient history. You're going to dissect or filter that specimen, and you're going to dilute or concentrate it. So that's kind of the first thing that we're doing. And then we're going to stain that specimen. So we're going to incubate that specimen with our CD markers of interest. So that's usually based on your panels that you have designed for your lab. In my laboratory, our basic leukemia lymphoma panel is a B cell tube, a T cell tube, a viability tube, and then kappa lambda tubes. So it's actually 4 or 5 tubes usually right off the bat. My cohort is actually designing new panels right now, so they're working on that, and I think they're trying to get that number of tubes lower now that we have newer flow cytometers that can read more colors in one tube. But this is, we all know how to set this up. We can do it pretty fast. And then you're going to lyse those red blood cells, and you're going to wash away any unbound antibody. After that, those stain samples are going to be run on the flow cytometer. The data is then analyzed by one of us, and then that report is formally interpreted by one of us and then finalized by a pathologist. So we call it interpreting in our laboratory. We're not interpreting the data and saying, hey, this person has this disease. What we're usually saying is, hey, here are all these markers and what these cells test for and what these populations test for based on gating, which we're going to talk about. And then we're going to hand that off to the pathologist. So we're handing them like some graphs and some PDFs and some numbers that we pulled, and then they are finalizing the interpretation. They're usually, our pathologists here, also looking at slides and looking at other things. So they're not just looking at the flow data, they're kind of looking at everything together to make their decisions. And we're just kind of in our flow laboratory doing our flow thing. So we will hand that off to them, and then they will kind of interpret and make their diagnosis. So sample preparation's that first step. We can do so many specimen types. I always say, like, you name it, we can flow it. Bone marrow, peripheral bloods, lymph nodes, tissues, usually suspected tumors, body fluids, all must be fresh. They cannot be collected in formalin. So that means that they, like, whenever they're in there doing whatever procedure they're doing, whether it's a fine needle aspirate or a biopsy in IR, interventional radiology, or something under ultrasound, they have to grab us a piece that they're not going to throw in formalin, or we can't do the testing. Our cells must be live and happy, just like your cells for the hematology analyzer. So same thing, they got to be live and happy for us to kind of see what we're working with. So no formalin for us, and we actually keep formalin away from our kind of area in our laboratory where we do that testing, just to be safe. For solid tissue specimens, we're going to dissect, chop, grind that tissue to release those white cells into solution. For us, this looks like just getting a scalpel and chopping away. You can use tissue grinders. Some places use stomachers and things like that. We find the chopping method works just fine for us. It's kind of fun. We like doing it. So that's what we do to chop up our pieces. We do get a lot of fine needle aspirates. So like these are like little, almost like a hair, not as thin as a hair, a little bigger than that, but small pieces of tissue in cell culture medium. So we use something called RPMI over here. And, it's kind of just floating in that 5 to 6 mils of that fluid, and then we'll chop it up. So it's not like it's, for the most part, we're not chopping like a whole big piece of something. So it goes by quick. It's not a big deal. And then for all of our specimens, we are going to measure a white cell count on a hematology analyzer. So the lyrics can do this, and I think we just don't have it validated at my institution because we can walk, across the hall and just run them on the hematology analyzer. We'd have to run our bloods and stuff over there anyway, because again, we need that data to be validated. So that's just kind of thinking smart, working smart, not hard. So we have to do this because we have to concentrate or dilute that specimen to be within the measurement limits of the flow cytometer. So our flow cytometers, they measure between 1 and 10 times 10 to the third per microliter of cells. So sometimes that means diluting something. If we have like an acute process going on, those counts get really high. Sometimes we have to dilute things. With our tissues, we get a little tiny fine needle aspirate of something. A lot of times that means concentrating it, and then we're kind of working with a more limited specimen. So we always check a patient history before proceeding to staining. This is, kind of something that makes my little blood bank heart sing, because this is something that we would do in the blood bank, is check a patient history. Um, the specimen may be limited in volume, and you may want to make different decisions based on that specimen. So we always just check that history, and we always are going to see what's going on with that. We're going to kind of see what's going on with the specimen, and then we're going to kind of evaluate from there. Most of the time, this isn't an issue. We usually have plenty of specimen to work with, but some of these cases can be complicated, especially when we run things like cerebrospinal fluids, which, if you know, shouldn't have any white cells in there really. And even when there is a disease process going on, they don't typically have super high counts. So the example I gave is a 2 mils of CSF with a white blood cell count of 5 cells per microliter. So not 5 times 10 to the third, just 5 cells per microliter from a patient with a new diffuse large B cell lymphoma diagnosis. We are going to prioritize the B cell section of that testing. So for us, that's the kappa lambda tube and the B cell tube. This is just an easy, I'm a visual person, so I like to throw nice, easy visuals into my visual aids. This is just kind of an easy little schematic of how we stain our specimens. You're going to add your stain and your specimen to the tube. You're going to incubate it. You're going to lyse your red cells. You're going to wash away that unbound antibody, and you're going to run the stained specimens on the instrument. Is there a little more to it than that? Yes, of course. It's a little more complicated than that. You have to know your volumes. Sometimes there's additional steps depending on certain things that we do, but this is just kind of the, easiest zoomed out way to talk about it. Specimens are often batch processed for efficiency, but we're pretty much getting them all day and just going for it. Care obviously must be taken to ensure correct antibodies are pipetted into our correct tubes, and that all tubes are labeled effectively, and that pipette tips are changed to prevent contamination of samples and reagents. That's just basic lab practice, but I thought it was worth saying here. I come from a molecular background in PCR. Obviously, PCR is really easy to contaminate. You can contaminate things in the flow laboratory too. It's harder, but you can do it. So we're all just really careful to make sure to be changing our tips at the right time, and making sure we're not pipetting out of our antibody bottles. The antibodies are kind of expensive, so we're making sure we're not contaminating our antibody bottles with other antibodies or with patient specimen. Each tube typically runs for less than 3 minutes on that analyzer. So we gather data pretty quickly, and we have to analyze it pretty fast. So we'll kind of take a preliminary look at it to decide if we need to reflex anything off of it. So we start with one panel, and then we kind of reflex some different testing if we need to. Like if we see something we think might be blasts, we'll run some blast markers. We don't have those in our standard panel right away, right off the bat. So those are things that we add on. So we're kind of taking a preliminary look at things, and then once we think we've run everything we need to, we will then formally interpret that data. And if we come across anything else that we think we need to run, we will add that on. So now we're going to talk about gating, which is basically what flow cytometry is all about. I'm going to be taking a pretty broad approach to this. This is pretty data heavy. I remember when I started the lab piece, and I've been a laboratorian for long enough that like my lab skills felt really good, and working at the bench wasn't super difficult for me. But the gating piece and the data analysis was like a whole new thing for me. So just bear with me. This is going to be a lot. But we're going to take a broad approach. We are only going to talk about peripheral bloods and bone marrows today. So I'm not going to show you data from tissues and lymph nodes and stuff, because it starts to get confusing. Looking at the different specimen types, of course, they look different. The data comes out a little different. Things stain a little different on the tissues and lymph nodes. There's just little quirky things about them that you get used to after seeing them. But when I started in the laboratory, we kind of start off with just looking at bloods and marrows. So that's how I'm going to kind of start you off today. We'll kind of discuss what normal looks like, and then some abnormal things to be looking out for. So going to give you a quick flow lingo lesson. We're going to talk a lot about dot plots and histograms, which are two of the most common ways of visualizing flow data. We're going to talk about gates. Your gate is kind of the border that we draw around a population or a quadrant of interest, typically on a dot plot. And then I'm going to talk about intensities. And these intensities denote the strength of expression displayed by a marker, typically in parentheses, weak, WK, or dim, which both mean the same thing for weaker expressions, and strong, which is STR, or bright, which is BRT, for stronger expressions. And you may be asking, Emily, why are there two different words for both of these things? So there's 4 words to connotate 2 different things. And there's probably more words than that. I know there is. But for the most part, there's these words because there's certain things that just have been referred to, since kind of the inception of flow cytometry. Like your blast area in a lot of things is your CD45 dim population. We don't typically call it a CD45 weak population, at least obviously in the data that I look at here in the US. I think different things kind of get discussed a little differently in different countries. I've looked in some textbooks and seen things called like CD45 weak. And then like on the strong and bright part of the analysis, like we say things are CD38 bright. That's our plasma cell gate usually for us. So you don't usually call it CD38 strong. And it's just the terminology. My boss, Jeff, likes to say that, we kind of have an oral tradition of flow. And I find that to be pretty true. But I find that to be pretty true in a lot of parts of the laboratory. There's just kind of ways that you refer to things. And that's just the way it is. So just a little bit of that flow lingo lesson for you so you're not lost when I'm throwing those things out. Just a little for reference, frame of reference of what that like weak or dim, strong or bright looks at. You have a plot that goes like 10 to the first, 10 to the second, 10 to the third, 10 to the fourth, 10 to the fifth, usually. We call usually anything positive if it's above 10 to the third on those plots. 10 to the third being weak, 10 to the fourth being what we call moderate, and 10 to the fifth being strong or bright. And on our histograms, we say greater than 20% is a positive when it puts out that percentage number for us. So here's our first example of gating. Gating is the process of grouping populations based on shared characteristics. This is the most important aspect of analyzing your flow data because your analysis is really only as good as your gating. As that forward scatter increases and forward scatters here on our y-axis and side scatters here on our x-axis. I apologize if these are kind of hard to read the lettering. I took screenshots from our software. So our granularity is here on this axis and our size is over here on this axis. So you can see we kind of have our lymphs over here and our monos over here. Somewhere in between them is what we'll call our CD45 dim population that I'll show you on our next page. But this is where blasts, plasma cells, basophils can fall. So this little tiny space, a lot of important stuff can fall here. And then we have our granulocytes out here, taking up a lot of room, being really complex, being really big. So that's probably an image you recognize if you've ever worked in a hematology laboratory because it's a really common image. But this plot actually doesn't tell us. I know I called these CD45 dim. They're not on this plot because we don't have any CD45 here. But we're going to see that here on this next page. So here is what we usually look at as a starting point for our leukemia lymphoma panels. It is a CD45 versus side scatter plot. So we have our CD45 here in our Y and our side scatter here in our X. And I have our populations kind of circled for you. CD45 is the common leukocyte antigen, so it is on all white cells for the most part. Of course, we have exceptions to that. We're not going to talk about those today. But we have our lymph population kind of up here to the left. They're usually pretty high on that CD45. And then this is where our CD45 dim is. So you can see why we don't call it weak because it doesn't fall all the way down here. We call it dim. And see how much better this is visualized than it was on the last slide? I'll show you a comparison in a minute. But we're most interested in our lymphs over here. And then here are our monos kind of to the right in our grands. It's not uncommon for your grands to sit a little lower on that CD45. But we're really interested in this lymph population, and we're also interested in the CD45 dim population where our blasts, plasma cells, and basophils can fall. We are looking at this population, and we also look at percentages. I don't have them on this slide. I don't think I have them on this slide either. No, I don't. But here's this comparison I said I'd show you. Here's our forward versus side, which is kind of the basic, you know, flow look. And then here's our 45 versus side. You can see that this green area that, like I said, contains any blasts we would be looking for. It's just really hard to separate. How am I supposed to circle or gate this when it's just so little right there? So it's really nice and discrete on this plot. So this is what we usually use to start out. If this, I don't have my percentages in here, but if this dim population in a blood is greater than 1%, or approaching 1%, we investigate it more by running blast markers or maybe a basophil marker, or trying to see if those are plasma cells based on some of our B cell markers that we have in there. If it's a bone marrow, we let that get up to about 3%. So here are blast staining basics, and here's where I'm going to start throwing those CD markers at you a little more. These are blasts that read the book, right? So just keep that in mind, that this is kind of what you're starting out at. But does cancer always read the book? Of course not. That would be too easy. They're usually CD45 dim, and they're usually larger than lymphs on forward scatter versus side scatter, which tracks if what we know about blasts is that they are usually larger as your maturation of your cells goes. Your cells kind of start big and they get smaller as time goes on, and as they grow up and decide what they're going to be. They're usually HLA-DR positive, CD34 positive, CD117 positive, and they're usually CD123 negative. Basophils are actually CD123 positive, so that's an easy way for us to figure out if something is a basophil or a blast really quickly. We most commonly see myeloid blasts. In my institution, a lymphoid process that would put blasts in the periphery or in the bone marrow is pretty rare. I did just have one this week, so, I guess kind of weird, but we really don't see them very often because that is a process that happens in younger people. I'd imagine like a children's hospital maybe sees them more frequently. But these pretty much indicate like acute myeloid leukemia or chronic myeloid leukemia or myelodysplastic syndrome, depending on the percentage and the specimen type. So for instance, if I get a blood and it has like 80% myeloid blasts, that's probably a full-blown AML. Whereas like if I get a blood that maybe has like 1 or 2% blasts going on, it could be either or, and that person's probably gonna have a bone marrow done. And for bone marrow, I don't think anymore, and I might be wrong or behind on this, but I think the WHO guidelines, the WHO guidelines say, I believe greater than 20% is more that acute myelogenous leukemia, whereas something less than 20% is usually this myelodysplastic syndrome. So we know that they are myeloid in nature if they are that 13 pos or that 33 pos. Remember, I talked about those a little bit in the beginning. That denotes that it's not a lymphoid process. It's more likely a myeloid process. Other aberrant markers can be present. So we can have like a CD7 or CD2 or a CD56 on those myeloid cells, because again, does cancer read the book? No, it does not. So sometimes you pick up some different markers that wouldn't normally be on myeloid cells on those cancerous myeloid cells. A good example of that is something called acute promyelocytic leukemia, which they're actually 34 neg, so that's always kind of a big thing that perks our ears up. They're also HLA-DR neg, and then they are 117 pos. So that's something that perks our ears up really quick because This disease is a medical emergency. It's actually super treatable, and has a really good prognosis, but you have to catch it early and they need to be treated very quickly because this affects coagulation for these patients and they sometimes can go into DIC. So that's something we're always looking out for in any specimen we're looking at. So here's that wonderful schematic I showed you in the beginning of our maturation cascade here. Again, this maturation area between your myeloblasts and your granulocytes is not fully shown. We may actually have multiple levels of maturation going on at one time, right? So anybody who looks at hematology slides is like, yeah, so it can get really complicated, right? Because it's never just, oh, you have all blasts or you have all, I mean, for healthy people, it is that you have all healthy cells, right? But a lot of times, even what we're looking at in flow, we'll have kind of a cascade of maturation going on. So we'll see, some blasts, but we'll see them kind of losing and gaining some of these things all the way up to having maybe some maturity going on, depending on the specimen and the disease state that's going on for our patient. So here is my first example for you. Let's see if I can move. There you go. So we have on, I'm going to try to, we're moving from kind of broad to specific every time we look at plots. So we're going to kind of zoom, this is usually our zoomed out plot is always our 45 versus side. So our 45 versus side is all events. We're looking at all of the events that we collected in this whole specimen. And on this specimen, we have 47% lymphs here, and we have about 9% in our CD45 dim area. I believe this was a bone marrow, and this might be the only bone marrow I'm showing you today. But 8% in a bone marrow or a blood, not good, something we need to investigate. So now we're going to zoom in on our CD34 versus side plot here. And we see that we have 8% CD34 here, and this was actually 8.6% in our dim area. So these numbers actually match pretty well, which tells us that these are probably mostly blasts, and there's probably not a ton else contaminating this gate. There might be a little bit. See how we have 8.6% here and 8.2% here. So there might be some grans coming in over here. There might be some, you never know, there might be some basophils in here. It could be some plasma cells. But for the most part, these numbers match up pretty good, which tells us that we do have some blasts happening. And then we'll come over here to our histograms. So remember I told you about our percentages and that anything above 20% is going to be positive. So we have our 34 is at 86 and our 117 is at 87. So those match really well, which tells us that these are definitely blasts. And then we have our 13 and our 33. Our 13 is at 97 and our 33 is at about 29. So our 33 is kind of weak and not super there, but our 13 is definitely there. That's enough confidence for us to usually say those are myeloid blasts. Our 33 is still positive. It's just kind of weak. This isn't uncommon sometimes in a cancerous process going on for us to only have positivity with one of those markers. So now we're going to talk about our lymphs, the thing that I've kind of told you is the most important thing and we haven't talked a ton about yet. Our mature B cell markers, and everything's 45 positive, right? All of our white cells. But our mature B cell markers are 19 pos and 20 pos. So that's really nice. That's really easy to remember. Your mature B cells are pretty much always 19 pos, 20 pos. And then they are going to have polyclonal surface kappa and lambda light chains in about a 2-to-1 ratio, kappa to lambda. That's very similar to what you would see on like a serum protein electrophoresis, which I think is about that 2-to-1 ratio, or 1.5, I believe. So then you have your apparent mature B cell markers. So we will say that a weak CD20 is kind of something that's gonna, clue us in that something's going on, and I'll show you what that looks like. And then CD5 and CD10, which aren't normally B cell markers. So when we see that on our mature B cells, so if they're 19 pos, 20 pos, and then they're 5 pos, that's definitely telling us that something is going on. And then we have our mature T cell markers. So those are usually 3 pos, 5 pos, 7 pos, and then they can be HLA-DR, pos or neg, based on how activated they are. And then our 3 pause usually is a subset of, we have a 4 pause, 8 neg population and an 8 pause, 4 neg population. Your 4 pause are your helper T cells, and your 8 pause are your cytotoxic T cells. So we're going to talk about our T cells first and kind of get them out of the way, so then we can head into our B cells. So our mature T cells are CD3 positive, and we gate ours on a CD3 versus side gate. So here's our CD3 and here's our side scatter. So this is about 19% of total. So we would say this sample, this is all events here. Anytime you see the black here, this is all events. So this is 19% of this specimen, we would say is about 19% T cells. And then here's kind of just a little guide of our T cell plots. So here's 3 versus HLA-DR. And remember, I told you kind of based on how activated those T cells are, we'll see our DR kind of moving over here. These T cells are not very activated. HLA-DR is the major histocompatibility complex class 2 receptor used to present antigen fragments to T cells. So, when we see that kind of activated over here, we are, saying that they're looking a little active. It's always positive on our Bs right over here. So these are our mature B cells that are positive for that, because that's what that antigen is actually really used for, or what that CD marker is used for. But when the T cells have it, that means that, things are ramped up. That person might have like a viral process or something going on. And then we have our histograms for our T cell markers. So we have CD2, CD3, CD7, and CD5. And what we're looking for is kind of that these all match within maybe 10 to 15%. So we have a 78% here, 71, 77, and 71. These all match pretty good for my liking. I'm happy with them. I think they look good. These are healthy T cells for the most part. And then here's kind of our helper and cytotoxic plots. We have 3 versus 4, and our helpers are here, and then our 3 versus 8, and this is our dual positivity quadrant. Our cytotoxics are here. So your 4-8 ratio should be about 1.0 to 2.0. In this specimen, you have 35 and 35. So those are actually pretty well lined up and look pretty good. And now we're on to our B cells. So we gate our B cells off a total CD19 gate. So this is all events. Remember when I told you that the black is all events here. So the purple is our B cell gate. And this is CD19 versus side. So this is complexity going this way, and this is our CD19 positivity. And this specimen has about 3% of B cells. The plasma cells are also CD19 and can fall into this gate. And you're probably like, Emily, plasma cells are B cells, right? So why are you talking about them as if they're different? Well, we do treat them differently because, like I talked about kind of at the top, something like multiple myeloma, we want to investigate those B cells separately from those plasma cells. So we usually use CD20 to get those out of this gate. So if we have a bunch of 19 positive stuff, we can separate out those plasma cells because they should be 20 neg, whereas our mature B cells should be 20 pos. We can also separate them out by size because plasma cells are quite a bit larger than our normal B cells. So that's something that we can kind of look at to solve that puzzle. So here are what normal healthy B cells look like. We have CD20 versus CD19 here. And so here is our actual mature B cell population. It's 20 pos, 19 pos. It's about 13% of total in this patient. And then we look at a 5 versus 19 plot. And that's because we're looking for any 5 pos, 19 pos cells here. These are our T cells, this CD5 positive population here. And you can see there's about maybe 1% in this 5 pos, 19 pos quadrant. This is what we call drag of our fluorophore here, which is FITC. This is pretty common, and this doesn't look like it's real positivity. We'd still investigate it and we'd look into it and make sure that there's nothing lurking in there. But to me, this is not something that's really making me super scared for this patient. And then we have a 45 plot, so they're all 45 positive, and then they are all 10 negative. So we know we don't have any 10 positivity for these patients, or for this patient. And then here are our kappa lambdas, our surface kappa lambdas. So we always have, in my lab, we do kappa on our y-axis here, and we have lambda on our x-axis. You get really used to looking at things kind of how you always look at them. So this is how we always look at them, but sometimes you open a textbook and they have them swapped. So just, like everything, like anytime you're looking at any kind of plot, you always got to know your axes, and that's why I'm being really cautious to always tell you what they say. So this is our lymphocyte gate, which is the red. Our purple is our CD19 gate. So our lymphocyte gate is all of the lymphs, including the T cells. And your T cells are what you see here and here in these quadrants that are kind of not kappa or lambda. So really common for things that have non-specific staining to form this spike look. We basically are getting this out, and we really only care about our kappa pause and our lambda pause. So this is a nice polyclonal look. But look what happens when we just do our 19 positive cells, right? They're all either kappa or lambda. We don't have anything in this spike area. So that's really normal, and that's really how normal B cells look. This is a really nice ratio, 55 to 42 looks pretty good. You see kind of an almost even split, but usually a little more kappa heavy, so that makes sense. And about a 2-to-1 kappa lambda ratio. So these look really good and healthy. Now we're going to talk about some less healthy ones. So when we're kind of looking at mature B cell disorders, we're kind of seeing if we have any clonal B cells. So they're either going to be kappa or lambda. So you're going to see a population that's only kappa or lambda. Sometimes it's all of the B cells, and sometimes it's just a small subset. So that can make it really hard. It's like finding a little bit of a needle in a haystack. We're also going to look for that weak CD20. So then going down the cascade, we look for either CD5 or CD10 positivity on those cells. And if we go down the CD5 route, which is more common, we will look for 23 positivity or FMC7 positivity. Our 23 positivity corresponds to a chronic lymphocytic leukemia, and our FMC positivity or FMC7 positivity corresponds to a mantle cell lymphoma. If we go down the CD10 road, that's more likely to be a follicular lymphoma. This is something that's typically happening in a tissue or lymph node, so I don't have any examples of that for you today. So now I'm going to talk to you about a couple of case studies to give you examples. I'm a learn by example person. Just like I said, I'm a visual person. So I think it's helpful to see these examples. I kind of showed you what normal looks like, and now we're going to talk about what abnormal looks like. I'm going to move my screen here so that you can see. We have our CD45 versus sides. Remember, I kind of said in this plot, we have the colors inverted, but this is our all events plot. So in this patient, which is a 70-year-old female with lymphocytosis, she's persistently fatigued. She has a white cell count of 17.5 times 10 to the third per microliter. 44% of those cells are lymphs, and that matches about what they see on the diff. And so we see that here. And then we see our CD45 dim population, which is only this is actually 0.3. It's kind of hard to read there, but 0.3% on that CD45 dim. So we're not super worried about this. There doesn't look to be a prominent blast population there. So this is our CD19 versus side scatter plot. So we can look at our B cells, and she's got quite a bit of B cells. 35% of total is pretty heavy. And I'm going to tell you that CD45 dim population is normal. So we kind of investigated it with what we have in these basic panels. And then I'm going to tell you that the T cells are unremarkable, but for time, I'm not going to show them to you. So here's that case continued, and here's those B cell markers. And I dropped what the normal patient looked like, this 5 versus 19 plot up here in the corner for your reference. But we have our 20 versus 19 plot here, and here's that week 20 that I talked to you about. So it's kind of draggy. It's not all this nice consistent population. It's kind of falling down. So we know that that weak CD20 is a hallmark of usually some kind of clonal process going on. So we're already kind of, our ears are perked up and we're like, that looks suspicious. And then we see our CD5 versus 19 plot here. And what I have circled in the pink here for you is our aberrant population. We shouldn't have really anything in this quadrant. And remember how this one was kind of draggy and coming up a little bit. And see how this is a nice discrete population. This is way more common for what we usually see for somebody who actually has a clonal B cell process going on. So there's that draggy weak CD20. And then here's that CD19-5 population, and it comprises almost the entire B cell percentage. So you'll see that your these two percentages match really well, which tells us this is all of our mature B cells, and this is all of our mature B cells. So this is a really nice, simple, straightforward case because you're not trying to parse out the healthy B cells from the unhealthy B cells for the most part. There might be like a little tiny healthy population in there, but it's really harder when it's the other way around, which it does happen when we catch things really early, which is always better for the patient. So here are those surface kappa lambdas, and I kind of have things going from broad. So this is our lymphocyte gate to our CD19 gate to our 19-5 gate. So we're going kind of from broad and narrowing our scope each time. This is like how you look at flow data. You're always kind of starting big and getting smaller and zooming in. So on our lymphocyte gate, we're looking at 71:1 for our kappa clone here, and you can see how all of these cells are kappa up here, but you can see how there is some polyclonal stuff going on. You can see we do have some stuff over here in the lambda zone. Here's our 19 gate where we're 97:2. So this number got even higher, which is telling us that it is really all those B cells that are showing that. And that's because these percentages are including your T cells here. So 27% of that is just your T cell spike that is negative for the kappa and the lambda. And then we got even more specific, and we really only gated our 19-5 population on this one. So then it's 99, and we call this 1 because you can't divide by 0. But you could see that there really is no lambda hardly at all to speak of here. And this is kind of what that clonal B cell process looks like. So this is a weak kappa clone. Here's a plot I didn't show you because we only run this tube on something. This is something that we reflex. We would have seen that clonal B cell population, we would have reflexed this tube, which is what we call our CLL tube. So this is FMC7 versus 23. And in the lymph gate, we have 23 at 78%, FMC7 at 1. In our 19 gate, we have 23 at 98% and FMC7 at 4. And in our 19-5 gate, we have our CD23 at 100 and our FMC7 at 1. So do we remember what that means for our patient? We have our aberrant CD5. We have a kappa clone in that week 20. We have a CD23 positive population. This is a chronic lymphocytic leukemia, pretty classic case. This is one of the most commonly diagnosed leukemias in the world. It comprises about a quarter of all new leukemias in America, and about 1 out of 175 chance is each of us has that chance in this country of getting this at some point. It is just a disease of the aging population, so it's something that happens a lot. A lot of times it's treatable, and we just do our best to monitor these patients. So now that we know about this patient, and if she continues to get treatment with us, we will be able to see and know that this is the clone that she has, and we'll be looking for it. We'll also be looking for her to develop anything new because sometimes, as we know, chemo treatments can make things change and can cause other problems. This is the last case I have for you. It's an 80-year-old male with a white cell count of 107 times 10 to the third per microliter and blasts noted on the peripheral smear. So anytime we see that, again, our ears are already perked up. We already are kind of looking into this blast population, and we might even start off running blast cell markers, and I believe we did on this patient. So this is our CD19 versus side scatter plot. We don't have hardly any B cells, so we're not going to be talking much about the B cells. This is 28 events, We kind of use the threshold of 100 events to really like start investigating something. We'll still look at these, but not really very much. We're not going to do kappa lambdas on them because there's just not enough there for us to do it. Here's your 45 versus side plot, and you can see what's this. Oh, it's a huge 45 dim population, about 94% of total. These cells are large on forward versus side. So I'm showing you this forward versus side plot to show you the size of these cells because it's relevant. Whenever we're looking at blasts, the size is something that we use to make sure, you know, everything's kind of making sense for us. So we do have a very small CD19, CD20 pos population, which is 3% of the lymph gate, about 0.05% of total. No 19 pos, 5 pos population, so that's good. And the majority of the lymphocyte gate is 19 neg 5 pos, so mostly here, which is your T cells. Remember, our T cells are 5 positive, but negative for 19. I'm gonna again verbally tell you that those T cell markers are negative. We just aren't gonna show them to you today because we're talking more about the B cells. Oh, that's our tiny little population of B cells. I think I highlighted it for you here in case you couldn't see it because it is very small. And then there's our T cells. So here are our kind of our, not our blast markers, but our things that we look for on blasts right off the bat in our typical panel. So we have HLA-DR here, which is positive at 99%. So this green is just this gate. So 99% of that gate is HLA-DR positive. 0% of it is 19 positive, 0% of it is 10 positive, and 90% of it is 7 positive. So that's one of those aberrant markers I talked about. We don't expect that 7 positivity, but when we see it, it again points us towards usually a cancerous process. So these probably aren't healthy blasts, especially given the sheer volume of them, but that 7 again points us in that direction. Here are our blast markers. So we have our 34, or our total, let's talk about our total 34 first. We have 34 versus side on this plot here. We see that our 34, total 34 is 93%. So these are nice little statistics we can insert into our plots. And that matches really closely with our total percentage of CD45 dim. That's about 99% of those cells are 34 pos. 46% are 117 pos. So that's kind of a little bit of a discrepancy. But again, cancer cells don't always read the book, and the 34 positivity is definitely enough for us to say that they're blasts. We do have that 13 positivity, which points us more to a myeloid process. And we've dropped this 33. Like I said, sometimes we drop one of these two because they are kind of coming and going at different points in that gray maturation cascade. So depending on exactly where these cells are at, they will have one or both of these. A lot of times they have both. I happen to just pick cases that this time they only had one. And then these cells were actually negative for all other markers tested. So they definitely didn't read the book with this 33 being dropped and that 7 being positive and that 117 being partial. But remember, I told you that anything above 20% is positive. So we did call that positive, but we, call that out to our pathologist that it's what we call a partial positive. So the conclusion here is we had 94% myeloblasts in blood for this patient. They were 34 pos, 117 partial, HLA-DR pos, CD7 pos, CD13 pos, and negative for all other markers tested. That is a classic AML diagnosis. This patient ended up having a bone marrow performed the next day with similar results. And this patient will be treated and then monitored with subsequent testing, like our other patient will be, including flow cytometry. The aberrant CD7 is nice for us because it can help us denote the cancerous blast population from any refractory blast population. So this patient will be treated, and then once they're in treatment, a lot of times they will develop healthy blasts because they're, healing their marrow or they're getting a transplant or whatever. That is something that we can help kind of denote those healthy blasts from the unhealthy blasts, because our unhealthy blasts will have that CD7, but the new ones shouldn't. So just a little main takeaway if your brain isn't broken from all that data. Flow cytometry is fast. Our data is generated really quickly. So it's a nice way to get an answer for a patient. You have somebody walk, we all know those. Um, we've seen those cases where the patient walks into the ER, with a hemoglobin of 5 and some crazy blast count or some really high lymphocyte count, and they need a stat heme consult and all these things. And if our lab is up and running for the day, then we're going to go ahead and run on that patient and try to get them at least a preliminary answer as best we can. And we'll make it a priority for our pathologist. So we do prioritize cases in my lab, depending on medical necessity. Flow cytometry is also really customizable. Your panels can be customized to your laboratory's needs. So that's something that a lot of labs are working on, and something that all these places are constantly doing and constantly changing and constantly tweaking as we learn. And then it's really good for looking at all leukocyte populations, but particularly good for mature clonal B-cell lymphoproliferative disorders. So I really thank you for listening today. This is the first time I'm giving this talk, so and for a new subject for me. So I was just really excited to spread the word about flow cytometry. And here are my references, just a couple. The human cell differentiation molecules website is kind of interesting if you want to go learn more history about how we came up with CD markers. And here's my email address if you have any questions. I had to re-record this talk because we had like a technology malfunction at the actual ASCLS. I did want to recap one question that I got from a very nice lady who she asked me in so many words, well, are you guys jumping straight to bone marrows, all the time? That seems like a really, difficult to collect specimen. It's very invasive. And my answer to her was that it's really up to the clinician what they're doing for these patients. But for the most part, they're almost always starting with a blood and then looking at a bone marrow. So we're almost never going just like straight for the bone marrow. Even when we look at that blood and we know the blood we're pretty cut and dry, like this is some kind of acute process going on. They're usually doing the marrow maybe the next day, maybe that day, depending on what's going on, but for the most part, usually the following day. So most people aren't getting a bone marrow done just for funsies. Same thing with, some of these things arise in lymph nodes in places first before they arise in the blood or the bone marrow. So sometimes somebody gets like a lymph node ultrasound and gets that looked at, and then we'll run flow cytometry on it, and that'll be kind of the initial diagnosis, and then we'll go to the blood, and then we'll go to the bone marrow. But those are decisions we don't get to make in the laboratory. But from what I'm seeing, our clinicians, I think, are making those decisions pretty effectively. So thank you for coming to my talk, and I really appreciate it. Please email me if you have any questions.